Good afternoon. This is Dr. Duke with typical and atypical antipsychotics. All right, to get us started, before I go into the etiology and describe some of the disease processes that we will be covering the psychopharmacology for this unit, I want to go over a few terms. So to start us off, what is psychosis? Since we are going to be learning about antipsychotics and psychotic disorders, we first need to define what these terms mean. So psychosis is actually the word that describes conditions that affect the mind where there has been some loss of contact with reality. Okay, so if someone becomes ill in a way that it's called a psychotic episode, or during a period of psychosis, a person's thoughts and perceptions are disturbed, and the individual may have difficulty understanding what is real and what is not real. Other terms to make sure that you can decipher or differentiate between is illusion, which is the misrepresentation of a real sensory stimulus. So, for example, maybe you looked at the corner of your eye and you thought you saw someone standing there and you look again. Or you look out at kind of the old Looney Tune cartoons, but you go look out and they think, oh, there's a pretty woman out there, or maybe a body of water, and they get up close and maybe it's just a cactus that looked like a woman, and maybe just the way that the sand divoted looked like there was some water, but there was not actually. Okay, so misrepresented type of real stimulus. Okay, hallucination is the perception of an object or event for any of the five senses. Okay, so tactile, visual, auditory. You can have different taste hallucinations. Okay, but in the absence of an external stimulus. So maybe you think you hear voices, but there's no voices there, okay? You're hearing people talk to you, conversations, crowded lunchrooms. Maybe you are, again, seeing, maybe there's trolls that you're seeing, or spiders coming on the bed, but there's actually not. Maybe you feel little pins and needles at your feet, but there are actually nothing that would be sharp or similar to that. That would be a hallucination. And then a delusion is that false belief, okay? So you've got this fixed false belief that you truly believe with all of your passion that that's true, that at that moment, I believe, maybe you believe you are a rock star, you believe you are Michael Jordan or Cleopatra, okay? Those obviously seem more kind of far-fetched, and you'll see here in a moment when we go over delusional disorder, that there also can be more everyday type delusions as well that are actually believable and possible, but no matter how many times we prove a negative, so for example, like an infection, you continue to still have that belief, or that, as we say, a delusion. So illusion, misrepresented real sensory. Hallucination, there's no external stimulus, but you have the perception, you're hearing or seeing, feeling it. And delusion, that is the belief. Alright, so as we actually get into the psychotic disorders, the main one obviously we want to start with is schizophrenia. So by the DSM-5 criteria, in order to diagnose someone with schizophrenia, they have to have 2 or more of the following for at least 1 month or longer in a period of time, and at least one of them has to be 1, 2, or 3. Okay, so 2 or more out of the 5 for at least a month. Alright. And one of those 5 have to be either a delusion, hallucination, or a disorganized speech. Now, other part of that to be diagnosed is that you also have to have continuous signs of disturbance that persist for at least 6 months. But during that 6-month period, it included at least 1 month of symptoms. So think of it this way. We have disturbance. Something is not quite right. We've been off the last 6 months. Our behavior has changed. But at least for a month during that 6 months, maybe you had an acute flare-up where the hallucinations were worse or louder or seemed to pick up, or the delusion, the speech changed, okay? So, but at least 6 months, and a month of that 6 month had to have been more worse. So think of it flare-up acute, okay? Now, they can be, okay, your symptoms can be positive, which we'll discuss here in just a moment more, but go ahead and take a break on that. Positive is things that should not be there, such as a delusion, a hallucination, okay, disorganized speech. And then your symptoms can also be negative symptoms, things that should be there. You should have some kind of care. You should have an affect, like a look on your face. You should have a sense of care and want, but maybe all of that is gone. Okay, I'm taking care of a patient at the state hospital who was a 23-year-old beautiful young woman who just had a break, and she was living out of a trash can, okay, living out of her car, eating out of the trash cans, absolutely didn't see anything wrong with it. No sense, no affect on her face, not really a smile, very blunt affect, and just speech was almost gone. There's also what we call thought blocking, which is a symptom, a negative symptom, where it's like the word is, like maybe they know what the word is, or literally it just goes, but you're asking questions and there's almost this kind of almost weird pause of, did they hear what I said? And you almost want to say it again and repeat yourself, and then they've heard it, but it's almost like they're internalizing what you said, and it takes a minute before the thought comes back across, okay? So just because you hear the word schizophrenia, it does not necessarily mean, okay, that they are always going to have a delusion, hallucinations, and disorganized speech, okay? Now, you can also have the emotional, the negative symptoms. So again, you can have positive symptom schizophrenic, okay? You can have negative. That negative, my female that took care of state hospital, never had hallucinations, delusions, and she spoke pretty well except for, okay, let's say except for, and this is where I guess it fits one of the three, because disorganizing, that thought blocking, she wasn't getting her thoughts across. It was taking time. You could tell something was not right. But she also had very disorganized, kind of grossly odd behavior, okay? And again, that diminished emotional expression, okay? So there are positive types and negative symptoms for psychosis. Positive meaning the things that should not be there. You don't want to be maybe positive for HIV. That's the way I try to think of it sometimes. And negative, the things that you want to be there and are not, okay? At least 6 months, 1 month of that period has to be kind of more like a definite, like you know that there was a flare-up and these symptoms occurred during that time, okay? All right, to continue with more of the diagnosis, of course, just like with most things for psychosis, we've got to rule out, is this because of severe depression? Is this we're in acute mania and we're so manic and haven't slept for 2 weeks and not eating and drinking correctly that we've gone psychotic? So we need to rule out, okay, is this more of a cause of depression? Is this caused more from the bipolar disorder? And obviously, if you're going to treat the mood in those cases, then the psychosis would disappear. However, when you're treating schizophrenia, okay, the mood, maybe you need to define too which one came first, all right? If the mood was there and then began the psychosis, I might give you a hint, okay? But if the psychosis had been there, that's so much because I can't shut the voices, there's nothing I can do to get it away, then maybe, okay, the depression came after the voices. That may be more of your schizophrenia than your depression or bipolar, okay? Of course, it cannot be related to a substance. You would not have true schizophrenia if you were under the influence of methamphetamine or cocaine, heroin, etc. PCP, LSD, any of those can be more hallucinogenic type drugs as well and can maybe mimic symptoms of schizophrenia. We also have to rule out schizophrenia. Is there a history of autism spectrum disorder? Is there already some kind of communication issues, socially awkward, sometimes bizarre behaviors? We need to rule out, is this more of autistic than the negative symptoms of schizophrenia as well? All right, so schizoaffective, they've made some changes in the DSM-5 compared to the 4, and we used to kind of have schizoaffective bipolar type, schizoaffective depressive type, and now they're more saying, well, no, this is that you have one or the other, period. You don't really specifying by types, okay? And what they're saying is that in order to be diagnosed with schizoaffective, you have to have an uninterrupted period of illness during which there is, okay, a manic or major depressive episode, concurrent with a schizophrenic episode, characterized between more of the following for at least a month. Okay, so what this is saying is that it's one of those things that almost sounds, well, does not sound like a bipolar or major depression. What this is basically saying, and this is how psychiatrists taught me when I was doing residency at state hospitals, how to differentiate between bipolar type 1 manic with psychotic symptoms versus schizoaffective disorder. Okay, so if I treat the mood, as I said before on the slide when it came to schizophrenia, then the psychosis should go away. Okay, now I treat the mood with schizoaffective disorder, but there's still lingering psychosis that exists. Okay, maybe we still have a fixed delusion. We still are odd in our thinking, our behavior, our speech. We're still not quite, there's still some of this underlying psychosis remaining even after the depression or the mania disappears. Then this becomes schizoaffective. Okay, that makes sense. So if it's a bipolar or depression, it's causing the psychosis. Once I treat the mood, the psychosis should disappear. If it does not, okay, I have the lingering psychosis, but the mood is treated, then, okay, then I have schizoaffective disorder. Schizoaffective is actually the #1 diagnosis for state hospital admissions. And if you think about it, my goodness, not only do they go through this being basically with schizophrenia and bipolar at the same time, or depressed and schizophrenia all at the same time. So it's double worse on them. Yes, a schizophrenic can get depressed. They may have seen symptoms that seem similar to mania, but nothing like a schizoaffective. They're having a true clarified manic or major depressive episode disorder throughout having the schizophrenia. Okay. During the time, it says there should be a period of at least 2 weeks with the delusions and hallucinations and the absence of the prominent mood. Here we go. So mood's now been treated, but we're still having 2 weeks of delusions and hallucinations are lingering and existing throughout. Okay. And it says mood symptoms have to be present for the majority of the total duration for the active and residual period of illness. Okay. So there's got to be mood symptoms there. They've had to have clarified things. You're going to, when you talk to a schizoaffective patient, a lot of times it does cycle. Maybe they've had mania with irritability. They've had depressive episodes. They may come every 3 to 4 months. Depends on their cycle and when their flare-ups and if they are also compliant with their medications. But in these peaks of even without a mood disturbance, okay, there is the psychosis that is lingering. Okay, so schizoaffective disorder. Now, on to delusional disorder. So delusional disorder is someone that has to have the presence of 1 or more delusions for at least a month or longer in a person who, except for the delusions, their behavior ramifications does not appear odd and functionally impaired. So this is what I'm saying. You've got to have this fixed delusion, this thought, this belief, okay, for at least a month or more, okay, despite what people may have told you or truth, you know, being right in front of you and knowing that isn't true, you still continue to have this belief, all right? There are non-bizarre delusions that I was just mentioning earlier that can actually, you maybe think you honestly feel like someone, your maybe partner has cheated on you, but have had all proof that there was never any infidelity in the marriage or relationship, okay? I had a patient at State Hospital who truly believed he had AIDS and was absolutely gung-ho, I have AIDS. I'm going to be dying. No, we've run tests, we've run these things like, you do not have AIDS. Yes, I do. Yes, I do. What we weren't 100% sure is if there had something in the past relationship, if he had stepped out and had had an affair in his marriage at one time, and we were wondering if that is where he thought it. But you could not convince this gentleman otherwise with lab tests in front of him. No, I know that says about, I have AIDS. I have AIDS. It's just, and bless his heart, just truly bothered by this belief that he had AIDS despite having those results in front of him. And then bizarre delusions being clearly implausible. Again, you know, I'm Michael Jordan, I'm Sensei from the Karate Kid, I'm, you know, all these different things. It's okay, and I know I live on a cruise ship in $1 million home, and I have this and this and this and this, and none of that actually exists. You may also see this for someone who maybe they're in the FBI, police are, you know, they have some specific special information that their other countries are out to get them, etc. That does go in to seem like it's almost paranoia, but can you have a paranoid delusion? Absolutely. Absolutely. I had a gentleman also at the same hospital, he would actually pull out, and it was his fishing license and another card, I can't remember, He was like, see, this is my FBI badge, and this is my you know, my work license, and something else he would show us, and it wasn't. But truly believed that he had a transmitter implanted in his body that was picking up and listening to the things he had to say. And he had to be very, very careful about what he said because the FBI was listening in. So, just an example again of a delusion. Okay, and that in that aspect, it was considered more of a paranoid delusion. Then there's unspecified schizophrenia spectrum disorder. Now, this has been changed. It used to be just called in the DSM-4 psychotic disorder not otherwise specified, meaning we're not really 100% sure what this is yet. We really don't know. It's usually been less than a month. We don't quite have a month. We know we're psychotic. Maybe it's only been a week or two. I don't know what this may be. They may be having delusions, hallucinations, disorganized speech, grossly disorganized in their behavior, maybe even catatonic. If you hear the word catatonia, it's actually like the person just goes in a state of just completely freezes out, maybe not moving. We used to learn wax-like. You could almost move their arm or leg or whatever, and it's like their limbs would actually stay in that position just as you can move wax around. And completely be in a state, which a patient at State Hospital once explained to me, it's like he would go into hell. And he's like, I'm literally in hell, and I can hear on the outside of me, but I can't respond, and I can't communicate with anybody. I'm living in hell. And so we have to give them, whether it's antipsychotics and benzodiazepines, trying to get them out of the catatonic behavior to come back forth. But he would just slump over and just, that's it. He would not respond to anything we had to say. Just there he went. Very, very bizarre in the way that works. But that's just an example if you're seeing catatonia throughout the slides. So, in other words, though, we really don't have adequate information to make the diagnoses yet, okay? So, this is what we say, all right, unspecified schizophrenia spectrum disorder, okay? Now, so etiology, oh, let me go back for just a second, too. So, a lot of times, too, in your Kaplan and Sodict actually had that postpartum psychosis. Sometimes we'll fall into this, but we'll end up calling it postpartum psychosis, but maybe that's a type of unspecified schizophrenia in the spectrum, because we're really not 100% sure of the cause, but maybe it just so happened to happen 48 to 72 hours after delivery, which is most of the time if that's going to happen, it does. And so we'll call it, okay, we'll put the postpartum psychosis underneath the unspecified schizophrenia spectrum. Okay, now, etiologies for psychotic disorders. They say for schizophrenia, there is a likelihood correlated with the first degree or second degree relatives, okay? 50% concordance with being a monozygotic or identical twin. Very, very interesting. So if you've got mama, grandmama, daddy, grandpapa, whatever, then that increases your likelihood of chancing of also having schizophrenia, and 50% chance more likely if your twin, identical twin, has schizophrenia. Now, just like any other thing with psychiatry that I always discuss, is we still don't know at the end of the day 100% exactly what causes these issues of the brain. We have a lot of theory and what we think. So some of the things that we theorize are related to biochemical factors. There is that theory of there is too much dopamine in the brain, too much dopamine leading to those positive symptoms, the things you don't want, right? The hallucinations, the delusions, the paranoia, okay? Also, there's a belief that maybe there's just too much serotonin. We talk about not having enough, maybe having too much. And GABA, having a unhealthy metabolism of GABA. GABA actually helps inhibits or prevents dopamine from going too high. It helps to regulate dopamine. And if our GABA is not working properly, then maybe, again, we have the hyperactivity of the dopaminergic neurons, thus causing us to be more paranoid, more hallucinating, okay? They also think about, and there's theories of looking at after people have passed away and doing autopsies, is there some change or neuropathology when we're looking at the brain? And what they found is that there has been some reduced volumes of gray matter and enlarged cerebral ventricles. Also, there's been some reduced symmetry, reduced limbic system portions of the brain, and anatomical abnormalities of the prefrontal cortex. So, whether schizophrenia could be biochemical, whether it could be neuropathology, genetic, Honestly, it could be a combination of all. In the way, it just depends on the person. And again, we don't have 100% definite of exactly what's causing it yet. All right, so let's begin to talk about some of the medications and drugs that are actually used to treat schizophrenia and other psychotic disorders. First, we're going to start with the FGA, which means first generation, okay? First generation antipsychotics are otherwise known as typical, sometimes also known as dopamine receptor antagonists, or DRAs, okay? So you may see it a few different ways, but I like to usually just say first generation or typical antipsychotics, okay? These are the oldies, okay? Older antipsychotics are also the typicals, okay? So you may also see the word, and that's what's kind of hairy, just hang in there with us. So there's first generation, otherwise known as typical, conventional, classic, or again the DRAs. Most of the time for the point of this course and for case study purposes and examination purposes, if you know that it's a first generation or typical antipsychotic, okay? So FGAs, or first generations, reduce dopaminergic neurotransmission in 4 dopamine pathways by blocking the D2 receptors, okay? They are specifically going to target dopamine, all right? Although individual effects may vary from patient to patient, general conventional antipsychotics share the same primary mechanism and do not differ much in their therapeutic profile, which when we get to second generation here in a moment will be greatly different, okay? So the only way that they may vary is a little bit of the muscarinic, the histaminergic, or alpha adrenergic receptors, meaning they're a little bit different side effect profiles, but for the most part in the way that they work and the primary mechanism of action, typical antipsychotics seem to work the same, okay? They're mostly, again, they are targeting that dopamine, okay? Largely effective, if you think about them, then they are targeting dopamine. So they are trying to lower the dopamine, okay? So therefore, they're probably, and they are, more effective for positive symptoms, okay? Positive symptoms, typical antipsychotics targeting positive symptoms. Now, highly effective, though, with disorders with psychotic thought. They work great. Guys, these are the old ones. These have been around for a long time. These can be scary medications. These are also the as needed when you hear people yelling in the emergency room, Haldol, okay? Which we'll cover in just a second. So haloperidol, Haldol is one of those, okay? They can be very effective, though, but they are ineffective, or relatively ineffective, for the negative symptoms. So they're not going to do anything really for your patient who is having the issues with, again, that sense of motivation, that care, affect. This is not going to help those patients. So here are the medications, and again, I put them in generic and brand name just so you can begin to relate to the medications so that you have them the same. So there's chlorpromazine or Thorazine, prochlorperazine, which is compazine, perfenazine, otherwise known as trilofan, trifluoperazine, stelazine, which I believe I understand recently. I had a patient who actually came to me on stelazine. It was recently discontinued, is my understanding, or no longer making it. Flufenazine or Prolixin, haloperidol, Haldol, loxapine or Loxetane, which that's coming back. Going to an APNA conference, they're actually coming out with more of a kind of an inhaler type version of loxapine that's starting to be kind of unrolled out for inpatient units for that acute agitation, aggression, and psychosis. And then thiouridazine, Mellaril, excuse me. You're not going to see that one as much just because of the potential side effects and liver damage. So we don't see that one really used as much. All right, so indications for our typical antipsychotics, obviously for our acute psychotic episodes, schizophrenia, schizoaffective, can be useful with delirium and dementia, maintenance of schizophrenia and schizoaffective disorders, acute mania and maintenance of mania, bipolar disorder, substance-induced psychotic disorders, delusional disorders, and depression with psychotic symptoms. Now, adverse reactions. Okay, so these are the oldies. These are more likely, I'm just going to say, and here's the thing for undesirable effects is the word stance. But you're going to see something pop out very, very suddenly too, is these are going to be the ones known more for the movement disorders, okay? These, when you're seeing the people have the flinching and the tongue rolling and the pill rolling of their hands or the jerking motions or tics and movements of their neck and so forth. The tardive dyskinesia, okay, and the EPS, all right, those are going to be more likely with these medications. Also, if we look at the word with stance, okay, S starting as sedation / sunlight sensitivity, we've got to teach about putting on sunscreen. You're more likely to get sunburnt with things such as Haldol. Does that mean you can't go in the sun? No, that just means that you need to be more cautious when you're going to be out in the sun. Sexual side effects are possible, okay, just mentioning tardive dyskinesia. Now, tardive dyskinesia is not going to just happen on day one. In fact, tardive dyskinesia may not show up until 6 months down the road when you've been on this medication or patients have been on this medication for at least 6 months. Then these symptoms may appear. Tardive dyskinesia a lot of times is associated with chronic and long-term use of antipsychotics. And the people that I've actually seen with tardive dyskinesia, bless their heart, have been on multiple antipsychotics, probably since they were younger or multiple different trials. And then, unfortunately, they're still having these movements, and tardive dyskinesia is not, it's not treatable. It can be a forever disorder caused from the medications. Now, we'll talk about that a little bit more here in a moment, but there are some things that may be able to make it better, but it's not going to ever completely go away. Okay, the A in stance, anticholinergic effects are agranulocytosis. Okay, so they can be very drying, constipating, urinary retention, okay, with the anticholinergic effects. Agranulocytosis, if you don't know what that is, so there's a low white blood cell count, okay, can drop your WBCs. If you think about that, if my WBCs aren't there, then I have to be extra cautious, okay, because, right, I'm more predisposed to infections and getting sick, all right? So what am I maybe looking for if I'm observing with my patients? Sore throat, malaise, fever, those things might be a clue. I might want to draw a CBC and check out how my patient is doing, okay? Agranulocytosis specifically is going to be related to an atypical we'll talk about here in just a few minutes. In neuroleptic malignant syndrome, okay, and we've got a whole slide on that, and I'll discuss that a little bit more, but a potential issue, kind of like we learned about serotonin syndrome with all the serotonergic agents, well, with these dopamine type receptor agents, okay, the way that we're working things, it can cause us to have NMS, or neuroleptic malignant syndrome. Cardiac arrhythmias are possible. There is some prolongation of the QT interval associated with this. And orthostatic hypotension can occur, specifically with thorazine as well, can drop the blood pressure, so especially when they stand up. So make sure that they're counseled to take their time standing up. And then the E, as I mentioned, extrapyramidal symptoms such as akathisia, which is the restlessness movement, kind of like my muscles, my body feels like it has to be moving all the time. Possible endocrine effects, there can be some increased prolactin levels. And eye effects, it actually can eventually change over the pigmentation, the retinal pigmentation of the eye, and actually cause blindness. So we have to be careful, and we'll learn about contraindicated with those who have glaucoma and things like that. So EPS, I was mentioning, akathisia is that restlessness, motor movement, like, oh my goodness, I cannot sit still. And you'll just notice they're talking and they're constantly moving their hands and just getting up, sitting down, pacing, and you talk to them and it's like, are you nervous? Yeah, but is it your body or your mind? No, my mind's fine. I don't know, my body, I feel like I gotta get up. I can't sit down. Dystonic reactions to dystonia. Now this is more of that stiffness, okay? So maybe arching of the back stuck, or oliguric crisis where your eyes roll in the back of your head. Maybe you have torticollis, or you've got where your neck is just stiff and can't move. You can't turn your head to one side and you're just looking at your eyes and your whole neck is stiff. Maybe you have issues swallowing. That's a big one to be on alert for, okay? Making sure that those swallowing muscles and everything have not become stiff and not able to swallow because you can aspirate. And then Parkinsonism is where maybe there's that shuffling gait, pill rolling type behavior, a little bit of tremor, that literally resembles a Parkinson's patient, okay? So we're looking for those. So as I mentioned, chronic dopamine blockade can lead to tardive dyskinesia, or otherwise known as TD, all right? Again, not an abrupt sudden thing that happens for most people at 6 months or beyond, okay? Now, if EPS, all right, if you've got some acute dystonia, some Parkinsonism, then you can use or actually give benzotropine, which is cogentin. Okay, cogentin is just an anticholinergic medication. Okay, it's going to reverse the dopamine blockade. That's the same thing that they can give. So, and also with the trihexyphenidyl, they're both, or Artane, it's both given for Parkinson's disorder. Okay. So we can actually give the treatment we give to Parkinson's to our EPS patients to help those stiffness type reactions. Benadryl, diphenhydramine, can also be given in injection form, and that may also do something also as well with in a histamine type effects to also help reverse the symptoms. Okay. However, though, I'm going to say propranolol is going to be more beneficial for your akathisia. So not that benzotropine, Artane, Benadryl, so forth can't do anything for it, but it's not going to be near the efficacy as using propranolol. Propranolol has a whole lot more studies and shown a whole lot more beneficial, okay, to reducing their restlessness and motor movement agitation of the muscles. Okay. Now, if also, again, you can develop tardive dyskinesia, you can try Benadryl as well. That may help to reduce some. Okay, again, it's not going to treat it. There was there for a long while, they talked about, oh, vitamin E, vitamin E. That was a big thing a few years ago, about 5 or 6 years ago, like, this is going to be the treatment. They were using vitamin E, like 800 units twice a day, up to 3 months. We have to be careful because it is fat-soluble vitamin, so we can't use it long-term in high doses. But they were saying, hey, this may help to reduce tardive dyskinesia symptoms and maybe even prevent. And I think that's where the research is becoming more shown. It may be a preventative, but as far as a treatment, very, very, very weak use to actually treat. I did, however, start 400 units twice a day on a lady on the geriatric unit just to see. She actually did have some reduced tardive dyskinesia symptoms in her hand, but her mouth movements, the tongue licking, smacking was still there. Now, and this is where I was saying, we talk about it in a second, sometimes if you have them on one antipsychotic that you know causes it, you may be able to switch them on over to something that, a different antipsychotic that actually can maybe help to reduce tardive dyskinesia symptoms or less likely, such as, which we'll learn about in atypical in a moment, clozapine, otherwise known as Clozaril, a lot of people have heard of, actually has efficacy to reduce movements. And olanzapine, or Zyprexa, another second generation we're going to cover in a moment, also has less likely to have the movement disorders with it. So sometimes a change can be beneficial. And this is going to sound completely backwards, but sometimes the whole thing is they say to stop. Every now and then, though, you're going to sometimes see when you've stopped an antipsychotic, then actually the movements become worse because all of a sudden you had something that was kind of help regulating the dopamine and it's not there. So that almost sounds very backwards. But sometimes a low dose back on something can actually be beneficial. And for you guys that are medical, already doing family practice and things like that, tardive dyskinesia, I think also you guys probably associated more with the Reglan. Back for GERD treatment and so forth, Reglan was coming out with that you have to be very, very, very careful. And I actually ended up inheriting a patient a few years ago that actually had tardive dyskinesia, not because of antipsychotics, but unfortunately because of the Reglan dose that she was on in her prior past. So for my visual learners, here's again the pseudo-Parkinsonisms, again the shuffling gait, rigidity, very slowed movements, tremors at rest. The dystonia, again, these spasms, stiffening, okay. Akathisia, the restlessness, pacing, and tardive, the lip smacking, chewing motion, involuntary movements of the body. All right, NMS, neuroleptic malignant syndrome. I truly feel like I maybe seen this one time on the geriatric unit. Now, whether the medical physician that was covering wanted to officially call it that, but when we did the assessment, to try to see, our gentleman had some shaking, what we call cogwheeling. So if you'll actually, some of the side effects from antipsychotics, and not just are typicals, but if you actually tell them to relax their arm, and when I say limp like a noodle, don't move your arm, I'm going to move it for you. And you'll place your opposite hand on top, kind of like on the bicep muscle of the other, and then move their hand upward to and you can actually look up on YouTube assessing cogwheeling of a patient. cogwheel rigidity. And as they go up, their arm will shake more and stiffen. It'll be hard, and you'll be able to feel those muscles. Now, you should be able to just move someone's arm up and down with I don't feel any rigidity when I do this now. But if I'm actually putting my hand, all of a sudden we're shaking worse as I'm bending my arm up, then that's our cogwheeling. So, and then when we did these things. Now, other symptoms of neuroleptic malignant syndrome can also be fever. Again, my gentleman had a fever, increased heart rate, just did not seem himself. But neuroleptic malignant syndrome can be a life-threatening emergency and even fatal in 10% of the cases. So, needless to say, you need to early detection, make sure you're doing treatment. To treat this, okay, we've got to stop the antipsychotic. You've got to get them on fluids, help them with temperature reduction, and then monitoring for more complications. So, because when I said you can have a fever, now I mentioned in the serotonin syndrome that you may have a low grade, not quite really considered fever any longer, okay? Here is the opposite, all right? Now we're talking 103, 104, 105 fever, okay? A lot higher fever. Blood pressure is up the roof, not just kind of a labile blood pressure like serotonin, but high blood pressure, okay? High fever, heart rate's up, breathing faster, diaphoretic, can be drooling, okay? Can be almost sedated seeming, very lethargic, increased muscle tone. We're very rigid. There's the cogwheeling, okay? So if you're seeing this, stop the antipsychotic. Just as we talked about serotonin syndrome, you got to stop the serotonergic agent here too. Stop the antipsychotic, okay? We're going to start them on fluids, help them again with your temperature, and again, it may be even that we're doing ice baths, anything to help to reduce fever. They may be giving them certain medications that are going to help also to lower that dopamine as well. All right. Drug interactions with antipsychotics, specifically with our typical antipsychotics. So anticholinergics decrease antipsychotic effect. Now, when we're giving benzotropine, otherwise known as cogentin, right? That's what we want. Yeah, that's what we want. I don't want it to cause these side effects. Can I give cogentin every day with my antipsychotic? Absolutely. Just be aware that you may have a reduced antipsychotic effect. Okay, but that may be what you want. With barbiturates, it decreases our antipsychotic concentrations, to be more aware also when there are certain seizure meds then, okay? Carbamazepine, up to 50% reduction. Ooh, there's that Tegretol, carbamazepine. We talk about that. The way that P450 hits and it can reduce other medications. It can be an inducer of the metabolism, therefore ridding them, okay? So be aware. Cigarette smoking. Oh my goodness, this is one of probably the hardest things working with psychotic individuals is they want to smoke. And there's actually, if you talk with patients, sometimes the way that it hits that nicotine receptors in the brain, well, actually patients hear that smoking de-stresses them and sometimes actually calms and lowers and quiets the voices. So I mean, I can understand wanting to have a cigarette. However, it makes our antipsychotics not work as well. So if you know for a fact, obviously the right answer, or the best answer choice is to help the patient to stop smoking, give them smoking cessation, nicotine patches, kind of help to wean them off, okay? At the end of the day, if they're not interested in any type of smoking cessation, okay, and maybe you've already sent them home once because you had them stabilized and they turned around and started picking up a cigarette and their medicine didn't work again, they're back, then we need to think about what are the dosing. You may have to have higher doses of antipsychotic to overcompensate for the cigarette smoking. Fluvoxamine, as I mentioned, we rarely use Luvox any longer. Here we go again. We mentioned drug-to-drug interactions. It can actually increase our Haldol and clozapine concentration, so we have to be more cautious. Amphetamines, because they are also stimulating the brain and hitting the dopamine receptor, which we'll cover more when we get to adolescent chapters, but that may actually exacerbate psychosis. So they are contraindicated with someone with schizophrenia, giving them an amphetamine. Can I get away with Wellbutrin? And sometimes yes, but that is because Wellbutrin is reuptaking what I already have. It's not necessarily telling my brain to produce more. So I'm a little less likely with the Wellbutrin, but you still have to be alert. Benzodiazepines interacting can actually cause respiratory depression, stupor, and even worsening hypotension when combining them together. When combining with clonidine, this was interesting, it can actually precipitate hypertension or hypertension, just depending on the alpha effects of it. And then valproate acid or Depakote interacted with the typicals can increase the half-life and the Depakote levels. So if you're going to use a typical and Depakote, you need to be aware you might be able to use lower doses of Depakote, knowing the medication can increase your level. So usual dosages, always try to include some things. These are from your Stephen-Stahl's textbook. Haldol is anywhere from 1 to 40 milligrams a day. There is a Haldol decanate injection. The dose of Haldol dec is 10 to 20 times greater, or 10 to 20 times the oral dose. So if you were on 10 milligrams a day, then you would be on 100 milligrams a month, okay? Or excuse me, 100 milligrams per every 2 weeks. It is given every 2 weeks injection. How to dose, you just let me start 1 to 15 milligrams per day. Give once a day or in divided doses, but no more than 100 milligrams a day max. Fluphenazine or Prolixin, 1 to 20 milligrams a day. There is also a decanate version, 12.5 to 100 milligrams per every 2 weeks, okay? Oral, 0.5 to 10 per day, and divided doses with a max of 40. Thorazine, 200 to 800 milligrams per day, and you can increase until symptoms are controlled. Viloxapine, or otherwise known as L'Occitane, which I don't think your Kaplan site quite yet had with the new kind of inhaler type version, but anywhere from 60 to 100 per day in divided doses, initially starting 20 per day in 2 doses and titrating every week to 10 days with a max up to 250 milligrams per day. Now, I'll let you keep going through these. I won't go through every one every time, but just so you have an idea, that's one of the things I think when I got out, I was like, okay, I know what these drugs are. I know that they can help, but like what dose always? Especially like these oldies that we try not to use as often because of the more EPS side effect potential. Then a lot of times we get kind of spaced out of, like, gosh, I didn't maybe go through school during the use of these as often. So it's always good to go back and use your Stephen-Stahl's book, your Hippocrates app. If you don't already have one on your phone, those are great references to look back at. So that of the up-to-date, the Dynamed, those things, so that you can look back and what are the current dosings. But these are out of your Stephen-Stahl's text if you'd like to go back, and it even goes into detail more about converting Haldol oral to the decanate and Prolixin, etc. All right. Now there are second generation atypical antipsychotics. Atypical. Why are they atypical? Because they are atypical. They work differently than are typical, okay? They are also atypical because they're not just going to work like you would automatically think an antipsychotic works. It doesn't just work on the positive symptoms. It also helps with the negative symptoms, okay? There is, when I say that, both positive and negative, there is some antidepressant type action here, some serotonergic type also hitting, okay? So there's something to do with that in the way that, and actually when you see this antagonism of the 5-HT2A, it's kind of used to always be thought of also as the poop out mechanism. So less likely to kind of poop out, also may be hitting that, which therefore also helping with the serotonergic type reactions and helping with these negative depressive type symptoms. Now, atypical antipsychotics, they're not just hitting the dopamine, right? Okay, so they are less likely to cause EPS and less likely to cause hyperprolactinemia or increased prolactin levels, except for that of Risperdal, which we'll talk about here in a minute, but less likely for EPS, less likely for the increased prolactin levels, okay? So, mechanism of action, the presumed antipsychotic effect of the second generation, again, blockade of the D2, but also, okay, having interactions with the serotonin receptors and the 5-HT2A subtypes. It's also hypothesized that properties account for distinct tolerability profiles due to each of the SDAs. So here's where we said earlier that the FGAs kind of all work the same, right? Well, SDAs or second generations actually work, and that's, I'm saying SDAs, they're here in SGAs, but it's the same thing, secondary dopamine antagonists or second generation, but have different chemical structures, receptors, different side effect profiles. So Risperdal may be very different than Seroquel, but also can be very different from Latuda. So as in where our first generation, Haldol, Thorazine, Selzane, they're all chemically similar, where our second generation are kind of our newer ones. Think about it, we've kind of come up with more research and more ways to make the medications better so that they may have actually different receptor affinities and less side effect profiles that may be purposely. That's why we're researching and making these medications to try to come up with better and better. Again, I already mentioned the both positive and negative symptoms. So here's our list. With an oldie but a goodie, and the original was the clozapine or Clozaril that came back out in the 1980s. Okay, and then followed after that, started our trend to look at, we had risperidone or Risperdal, olanzapine, Zyprexa, quetiapine or Seroquel, ziprasidone, which is Geodone, aripiprazole or Abilify, paliperidone is Vega, and Senapine is Saphris, elioperidone is Fanapt, lorazepam is Latuda. Two very new ones that were in your Kaplan and Sodic and have come out since your book was came out was the brexpiprazole, which is the Rexulti, and the cariprazine or the Vraylar. All right, so indications for our atypicals, our newer ones, right? Schizophrenia, acute mania, okay, sounds the same. Can actually be used for treatment resistant and adjunctive to the treatment of depression because, again, remember, these are also targeting those serotonergic type receptors, that 5-HT2A, therefore can be useful for depression and anxiety. Also post-traumatic stress, anxiety disorders, behavioral disturbance with dementia. You're going to see these more. Yes, will you see Haldol given in instances as PRN for those aggressive behaviors? Absolutely, in delirium cases. But for long-term and maintenance use, you're going to see more of your second-generation atypicals used. Also with the approval, and these are the classes that have more of the child adolescent approvals, where they actually approve for autism spectrum, Tourette's disorder, and things like that. And you may also see with very aggression, conduct disorder, and behaviors with ADHD, you may see atypicals added on. So adverse effects of these. So pretty much many of the very same side effects as the first generation. Sexual side effects, look, can have nausea, vomiting, dry mouth, constipation, can be sedating depending on the medication you're using. Now this is where we differ a little bit. So one good thing we said was these were less likely, doesn't mean they're not, but less likely, okay, to cause the EPS, right? Less likely to increase prolactin levels. However, we are more likely to gain weight, okay? More likely to put a patient at risk for metabolic syndrome. And I include the symptoms just in case you weren't sure what that was. So you've got to have weight gain, dyslipidemia, altered glucose metabolism, and hypertension, okay? So our BMI is up, cholesterol's up, sugar's up, hypertension. A lot of times one of the other things, and some people may, if you already work in psych, may have quality measures in place at your clinic or in the hospital where they're doing the waist measurements as another part of those things to kind of rule out metabolic syndrome. But when you have this, so if we're looking at the higher ones, which drugs of the newer ones are most high risk for metabolic, is the clozapine or Clozaril. Unfortunately, clozapine can be absolutely amazing, and at the end of the day can really be sometimes our last resort, and I'll tell you in a second, but can be a great antipsychotic. Unfortunately, can cause weight gain. In fact, clozapine can actually reduce movement disorders and may be a good option for those who've experienced tardive dyskinesia with other first-generation antipsychotics. But you've got to be careful with their metabolic risk. Now, I mentioned, well, if that's so good, why in the world do we not start it? Okay. Well, unfortunately, clozapine comes with a very specific risk factor. In fact, pharmacies will not even fill without lab work. Clozapine/Clozaril can actually cause the agranulocytosis, and this is the one that is most known for the agranulocytosis, okay? So if our WBCs drop below 3,000, our absolute neutrophil count below 1,500, then we're going to actually have to stop the clozapine. You actually get put on a registry, and then you never go back to that medication again. So it is a very straightforward thing. And when you're first starting this medication, you actually have to have weekly CBCs to follow up. And then after so long a period of time, I think it's 6 months, you actually go to monthly. Then once you've proved for that for at least 1 to 2 years, then you may go on monthly lab draws. Or excuse me, so it's once every week initially for 6 months, then it's every 2 weeks thereafter, and after 1 year, then you can go to once a month. But I will tell you, these pharmacies will not even fill. Some of these pharmacies will not even fill clozapine without a copy of proof that your WBCs are not below what they need to be. Olanzapine or Zyprexa also, it's interesting, both of the medications that have the lower risk for EPS are also the most high risk for metabolic issues. I wonder if there's a connection there. But olanzapine also can be a great option for those that have less potential for EPS. However, people tend to gain weight on Zyprexa. Okay, it can be a great drug, get you stabilized quicker. However, you might have to look at a long-term medication, something other than due to the weight gain. Our metabolic ones that fall in the moderate category was the risperidone, paliperidone. Risperidone and paliperidone are pretty much sister drugs, by the way. A lot of times people can actually start the risperidone. If you do well, you can actually transition over to the paliperidone version of the decanate, which is otherwise known as Invega Sustenna. Okay, and Risperdal also has a long-acting decanate called Risperdal Consta, but they are one kind of the same, so it depends on what they are. You know whether they tolerate the next one. Good thing, the difference is, why in the world would I go, okay, well, if there's an injectable for Risperdal, then why would I need to go on Invega? Well, Risperdal Consta is about every 2 weeks, where Invega Sustenna is a once-monthly injection. You may have a little bit more compliance with someone getting the injection once a month instead of every 2 weeks, trying to track them down, make sure they're coming in for their injection. Quetiapine, otherwise known as Seroquel, okay? There is a moderate, it's kind of hit or miss. It is hit or miss. It depends on the dosing that you're using it for. And then elaperidone or Fanapt, again, that is more the weight potential only really for the elaperidone. It's moderate weight factors, but not as much the risk factors for the sugar and cholesterol. The ones that are more low, or the lowest metabolic risk, would be your ziprasidone, which is your Geodone, aripiprazole, okay, lurasidone or Latuda, and actually Latuda had some studies that showed when it first came out, drug reps were saying it actually dropped people's sugar. So you had to be careful with your diabetics and so forth to watch it with lurasidone. Elaperidone is the lowest for dyslipidemia or cholesterol issues. That might be a good option for those that you knew already have a history of high cholesterol. And acinapine, otherwise known as Safras, is a lower metabolic risk. If we're looking at ones that are kind of right now, the big ones that are really put into display is the Abilify and the Latuda. Those are kind of being the ones that are most commonly thought of as the lowest metabolic risk. Could you still gain weight on either one? Absolutely. Okay. Clinical pearls, so olanzapine, one of the antipsychotics, I already said, most associated with weight gain and metabolic. Quetiapine can lead to weight gain and triglyceride levels, so maybe a second option it goes into, say, Risperdal, again, weight gain, triglyceride levels. Risperdal, though, what I mentioned earlier about the prolactin levels, Risperdal, unfortunately, is the one that it can still increase prolactin levels. Does that mean that I have to check prolactin levels all the time? No, okay? But if you begin to start having symptoms, you're having discharge, breast growth, enlargement, so forth, maybe we're breaking bones easier and things like that, we might want to be checking some prolactin levels and see where we stand, and we may have to be dose dependent on that or switch to something that has less likely of a chance. All right, so here's where I was talking about the elevated prolactin levels, okay? Because of that blockade of the dopamine receptors, that's going to cause that. It's going to cause a breast enlargement. And a lot of times, unfortunately, you'll see this with our males and females. With females being also, if we're missing some menstrual cycles all of a sudden, there's been some sexual issues during sex, orgasms inhibited, then we may need to be checking our prolactin levels. So again, more usual doses from your Stephen Stahl's textbook. Clozapine or Clozaril, okay, depending on the plasma levels, the trough level of about 350 is where you're hanging out. Again, clozapine is the one. Please, please, please remember with the granulocytosis type risk factors, okay? There is its own registry, again, for the WBCs and how that medication is prescribed. You can review and see your Stephen Stahl's for more of a chart and prescribing on how to prescribe and expectations. Aripiprazole or Abilify, usual dose range of 15 to 30 milligrams for schizophrenia and for mania, and then 2 to 10 milligrams is how we're augmenting depression. They do now have the Abilify Mantena, which is the once monthly injection, so that is a decanate version of Abilify available as well. Risperidone or Risperdal, again, I mentioned the Risperdal Consta is available, but the oral normal dosing is 2 to 8 milligrams for psychosis or bipolar, 0.5 to 2 milligrams per day using with children and elderly. So if we're treating autism spectrum, Tourette's disorder, if we are treating with dementia with behavioral disturbances, there is an injection for those non-compliant of 12.5 to 50 milligrams IM every 2 weeks. And right now, none of the injections are approved for child and adolescent. They are adult. Quetiapine or Seroquel, there is a short-acting and extended-release version. Not an injectable quite yet, 400 to 800 per day. I've seen up to 1,000, but no more than 800 usually is the max. And around 300 for bipolar depression. Depending, again, you may see lower doses used for children, post-traumatic stress disorder, so forth. I want to make sure that you understand that quetiapine, you're going to think, oh my gosh, that's the thing that we give people to make them sleepy. And in reality, yes. I mean, it does have some very high histaminergic type receptor in the way that it functions, but the higher the dose of Seroquel does not necessarily become more sedating past 200 milligrams. Okay, let me say that again. Past about 200 milligrams, it doesn't usually become any more sedating. In fact, it actually begins to work as it should. It actually starts to target the dopamine and the serotonin, and you get the reactions that you're treating and using it for the mood stabilization beyond the lower doses are what's sedating, okay? The higher the dose, the more it's actually being using its function. Olanzapine or Zyprexa, 10 to 20 milligrams per day. Again, that's the one we got to watch out for weight gain, but can be very beneficial. Less movements also with Zyprexa noted. A great adjunctive, especially for our elderly and our dementia who are forgetting to eat and may need a little weight and having some depression. Even as low as 2.5 to 5 milligrams can be added on once daily. Ziprasidone or Geodone, you've got to take with food. At least a 500-calorie meal to be effective. The usual dosing is at least, or most normally, twice a day. You will see it sometimes because of some sedation given at night or with supper due to having that 500-calorie meal. More, the paliperidone, in other words, the sister to Risperdal. Okay, Invega, there's Invega Sustenna. You can actually first start the oral to make sure they can tolerate, and then move across to the oral, the Sustenna. And then there is also now, which is a monthly injection, and there is also a 3-month injection version of the Invega is out as well. And it's the Trensis. Acenapine, or otherwise known as Safris. Okay, this is a sublingual, and I'll tell you guys, when it first came out, it was the most bitter, gross, nasty type medication patients will tell you. They hated it. Oh, they hate it. So what they've come out with is a black cherry, and I'll be interested. I haven't heard of any more flavors releasing. The black cherry patients tolerate better. They say it's better, okay, and even children, they're using it now. So you really didn't want this nasty, bitter thing because one of the things is you can't eat or drink for 10 minutes afterwards because you're just washing it away. And the way that it's so nice that it works is that it's sublingual, it melts away, it gets straight into that blood system and kind of react. It actually can kick in and work quicker. Safris can be very sedating. So despite its dose range of usually twice a day, most people just dose it at bedtime because of the sedation factor. And this is a pretty strong one to get you to sleep. But the black cherry, they said, is tart. It's a strong cherry, but it's more tolerable. And looking at this, I wanted to go back to remind you guys too, or mention. So I went over olanzapine. There's also a Zyprexa Zydus. There's actually also a Zyprexa Relprev decanate, but it's had so many risk factors and constant observation. Many people do not use the injectable form of Zyprexa. But there is, or not the long-acting version. Let me clarify that. Long-acting is like Relprev. We haven't used as often. But the Zydus, there's Zyprexa Zydus is actually a sublingual as well. Again, and it can just be a quicker type reaction, and we can dose it at bedtime to help you sleep and to kick in quicker in that acute aggression or agitation. Eleoperidone or Fanapt, they actually say is chemically the most closest component to clozapine, which is interesting because it doesn't have as close of the, has a lot less potential for the issues with the cholesterol though than clozapine, but chemically most similar in the way that it works and its reactions for patients is the Fanapt. Lorazepam or Latuda, that's more of a newer one. That is the one when we used to do classifications. They actually tested rats up to 500 times the dose, and there was no fetal effects for the baby. And so they actually labeled it as a Class B antipsychotic, and actually it was our only Class B antipsychotic that can be given for psychosis for schizophrenia or bipolar. And that they're saying more safe for pregnancy. So this is, lorazepam was kind of our first option, besides having the long-term research of Haldol. Haldol was not a Class B, but Haldol just had so much research to show that it would be safe, and there were no effects on the fetus or the baby with mother being on Haldol. But Latuda was kind of a little bit lighter option to try. And now lorazepam has to be taken also with food to work beneficial, at least 350 calorie meal. So it's best to dose this at supper time. And this is something, even as a clinician myself, I have to remember to remind patients that it's going to be best taken with food for it to absorb and to work properly. So again, with food is going to be your Geodone, okay, and your Latuda. All right, so newer one, the brexpiprazole, Rexulti is coming on the market more. They're saying also less weight gain, etc. with it as well. Anywhere from 2 to 4 milligrams a day, having some efficacy with depression in the lower doses, up as low as 0.5 to 2 for depression. And then the Vraylar is coming out, not any indications right now for depression, but for schizophrenia and bipolar, anywhere from 1.5 to 6 milligrams, with the median is most people on about 3 milligrams a day. Just some little tidbits to kind of make sure, and I try to do those along the way. And if I forget some things, that's what's so important about please participating and peeking at those discussions, because those discussions we purposely for the grading rubric going into a little bit more detail about the drugs. It stimulates a conversation between the class. So as a community, we're learning more about these drugs and kind of having a discussion and finding out things that maybe we didn't know. Little secrets, tidbits, and those who are already currently practicing and those who have never practiced, maybe those who just worked psych of other lives and seen things, we can learn from each other. But some clinical treatment tidbits. Obviously, there contraindications of treatment with using antipsychotics. We have to be obviously very, very careful with. There's been ever a history of allergic responses to antipsychotics. Any ingestion of a substance that may interact with antipsychotics. Severe cardiac abnormalities. I mentioned there can be some QT prolongation. Does that mean that I have to get an EKG every single time I start an antipsychotic, I change an antipsychotic, I increase an antipsychotic? Not necessarily. Is it clinically recommended that yes, and actually I think it's one of those standards for before they're admitted to the psychiatric unit. Is there an EKG on file? Absolutely. Okay. We're looking to make sure that QT prolongation is not above 450 for a male and 500 for a female. Now, however, in your outpatient practice, it would be great to have one all the time. We're going to run into, and you're going to see patients, unfortunately, a lot that you take care of or in the lower socioeconomic status and don't have the money. You're going to have no insurance. EKG can run you $200, $300, depending for cash pay. They may not have the money, but still need the treatment. So just look at the whole picture of themselves. Any cardiac history, any sudden death in their family. Was their heart rate below 50? Is their blood pressure over a certain amount? Really look at the standards, and if they fall outside of those standards, then yes, you may have to have one, and come up with something, a way to payments or something for your patient to be able to get the EKG that is warranted. But most of the time, it is not something you have to do on every single patient every time. Okay. Again, that's more outpatient. If you're inpatient, should be no reason. Grab the EKG. Okay. So if they are high risk for seizures, it's not necessarily saying that antipsychotics cause seizures, but they do lower the seizure threshold. Therefore, you're more likely to have seizure. Can aggravate or cause neuroangle glaucoma. And so you want to be very, make sure you avoid that as well. And the presence of tardive dyskinesia. Again, what I mentioned earlier, doesn't mean we're not going to use it, but you've got to be mindful, maybe go for those that have less likely. Okay. So usual assessments, because of the way that these work, make sure a lot of these can be very damaging to the hepatic. So we're going to get some liver function test, a CBC, EKGs I already mentioned. You know, because of the, especially if you're on second generation, it is warranted about every 6 months that we run we're looking at thyroid, we're looking at their lipid panel, we're looking at their, again, their liver, we're looking at their total cholesterol, their triglycerides, making sure, their hemoglobin A1C, making sure that we're still keeping things in check. Elderly and children are more sensitive to treatment, so it's kind of the start low and go slow, or start, yeah, sorry, that should say start low and go slow, and that's actually going to be in general for anybody, even not just elderly and children. A lot of times you're going to start low and go slow. However, depends on the symptoms. So let me want to say that depends on the symptoms. If they are acute mania, very high aggression, you may have to front load, but then you'll eventually, once you get them more stabilized, then we can decrease from there. And I think that's what has happened. So when I was doing my PowerPoint, and I'm going to fix this, what it looks like is there's some, one of my references ended up on this page, so I will edit this. But another point of the thing I was just saying is, so a maximal effect of any dose. So antipsychotics, I will actually teach patients that they work quicker and faster usually. But you know, you're going to see a difference. I say that they work quicker and faster, that you're going to see a difference within the first couple weeks. And especially my really depressed, anxious patients, I'm going to say, you know, hey, what's great about these is you're going to get a difference in a week or two, maybe in a few days, which is really, really great. However, to be still fully, completely in your system, therapeutic, just as like an antidepressant, it's still going to be the 4 to 6 weeks to get the maximal benefit of the antidepressant. Even in some cases, and some, depending on some readings, up to 12 weeks to really fully get the exact idea of how the medication is going to react. But as a standard, according to your Kaplan and static, is usually in the first 3 to 6 months after a psychotic episode is usually a period of stabilization. So it's been at least 3 to 6 months since your last psychotic episode. We're considered stable. At that point, then we can start to decrease the dosage about 20% every 6 months until the minimum effective dose is found. And then usually, so kind of another rule of standard is that you're usually maintained on an antipsychotic for 1 to 2 years after your first psychotic episode. Now, what I didn't mention, I need to go back up to etiology real quickly to say is most people's first break for bipolar disorder is about 19 years of age, and schizophrenia about 21. You guys, this is actually early college age. When we see most of the time when someone's going to have a break or a first psychotic episode, it is in the early adulthood, early, late adolescence, and, you know, whether there, again, your brain's still not fully developed or just because of time in your life where things are shifting and changing, may have brought it on. We don't know, but that seems to be the most peak. So around that age, or when your first psychotic episode is noted, at least 1 to 2 years of treatment. And then usually we have to keep you on it for 5 years if you've had a second episode. If you've had 3 psychotic episodes, by your 3rd psychotic episode, there's most likely not going to be this weaning and let's try without medications. It's going to be a lifetime unfortunate maintenance. The more and more that your brain continues to have these episodes, the more damaging things can be. So the lifetime maintenance option is there, trying to help prevent, which leads me kind of into my next slide. For long-acting depot medications, okay, they are being pushed more and more and more because of because especially with this group of individuals with psychosis and their statistics and rates of noncompliance, that if we can go ahead and have a long-acting injectable there, then we're not going to have to put the person through as many flare-ups and relapses and damaging to the brain, and actually can have better outcomes. So another statistic too is the younger that you are when you have your break, the less likely and the more poor outcomes you're expected, versus if you have outbreak and an episode of psychosis later on in life, then you're actually projected to have more of a better prognosis because there's less damage to the brain after reoccurring flare-ups and episodes. So that is why they are being pushed more and more and more. And it is a nice way. Hey, hey, you only have to come in and get your shot once a month. If your family members trained, go to the pharmacy, you get a shot. Don't have to remember your medications every day. It can be a great, great thing. All right, so there are the references for this lecture. Again, if you guys ever have any questions, concern, clarify anything, please post a question in this discussion forum. And if not, also please participate with this unit. There's both a typical and atypical presentations this week. Please be a key part to play a part in our community to respond to those questions, your fellow students who have really worked hard on these presentations this week so that you can be better prepared to take care of psychotic disorders. All right, you guys all have a wonderful week. Thank you.